prior to the TALAPRO-2 study, in a first-line CRPC setting, what was the standard of care and how has TALAPRO-2 changed that?
Yes. In patients who have newly diagnosed mCRPC and who have homologous recombination repair mutations, and where we are starting them on enzalutamide. So these are the three conditions I think about which have to be met, and then I talk about talazoparib in those patients. So regardless of patient disease volume or frailty status, as long as they are candidate for enzalutamide and they have HRR mutation and they have new mCRPC, I think those patients ought to know about the combination with talazoparib, and I discuss these data with them. Yeah.
So aside from prior seizure history, are there other factors that might make someone not a candidate for enzalutamide where you might prefer one of the other agents that we use in mCRPC?
Yes. So if I'm using abiraterone in mCRPC, obviously I will not combine talazoparib with enzalutamide because we don't have the safety efficacy data. So yes, answer is it is only for those patients who are going to be starting enzalutamide in the mCRPC. And it turns out enzalutamide is a very commonly used drug in mCRPC. And based on the fact that there are 25% patients who can harbor homologous recombination repair mutations, for example, if you look at the all-comer cohort, more than 25% patients had HRR mutations when all patients were being recruited on the trial.
And were these based on tissue testing for NGS, or was ctDNA allowed also as a qualifying way to identify HRR alterations?
Yes. So tissue testing is standard in our clinic, and I'm sure we are going to discuss about need for testing in a moment. But in talazoparib, like TALAPRO-2 trial, 100% patients had prospective tumor tissue testing, which I think was one of the biggest strengths of the trial. We knew which patients have homologous recombination repair mutations using the gold standard. We also obtained ctDNA testing for these patients, although not for all patients, but a significant number of patients had ctDNA testing, and we'll be reporting the data on how concordant or how similar results were there. But having said that, I think tissue testing remains the gold standard, and everyone had tissue testing done, answering your question on the TALAPRO-2 trial.
And before we wrap up, any thoughts on what it means to be a first-line mCRPC patient as what was represented in the TALAPRO-2 population?
Yes. This discussion often comes up. I have heard discussions about that this patient population doesn't exist, who have not been exposed to novel hormonal therapy. And I'm so glad to have this opportunity to discuss this. I cannot really elaborate the data we'll be presenting in AUA meeting, but I can tell you majority of the patients who were diagnosed to have mCRPC in the United States in the first quarter of 2023 were not even exposed to novel hormonal therapy. And it doesn't mean our community colleagues, or whether surgeons or radiation oncologists or medical oncologists, don't know how to practice medicine. It turned out I realized that the most common way prostate cancer is diagnosed in the US is localized prostate cancer. De novo metastatic prostate cancer only happens in less than 10% of total number of prostate cancer. And if you look at those patients who are seeing a radiation oncologist or a surgeon for their definitive therapy of their localized prostate cancer, we know that many of them, based on the real-world data, based on many trials data, 30 to 50% patients will unfortunately have biochemical recurrence of the disease. PSA comes back, and the standard of care for those patients is more or less single-agent ADT, whether intermittent or continuous. And unless they are lost to follow-up, those patients usually get this androgen deprivation therapy through their local urologist or radiation oncologist for a variable amount of time before their PSA starts rising. And at that point of time, when we do scans, whether conventional scans or PSMA PET scans, they are found to have metastasis and they are diagnosed to have mCRPC. And I think that is the reason why so many patients with newly diagnosed mCRPC had no exposure to novel hormonal therapy because there is no real indication for novel hormonal therapy in these patients. Even with those patients who unfortunately are lost to follow-up or who just don't follow up with their physicians and they develop metachronous metastasis. So if we combine this metachronous MHSPC and synchronous MHSPC and see what is the use of novel hormonal therapy, there is a level 1 evidence for use of ARPIs or novel hormonal therapy in metastatic hormone-sensitive prostate cancer. Till last year, less than 50% patients received novel hormonal therapy for their conditions. And then we are seeing a new patient population emerging which has locally advanced or high-risk localized prostate cancer. And they are receiving a limited duration abiraterone for 2 years. And then if you add those patients who start, say, novel hormonal therapy for newly diagnosed MHSPC, and they have excellent response, many of them are actually wanting to take a break from these therapies after being on intensified ADT for 4 or 5 years. And those patients, when they develop, all these patients, they develop mCRPC, they are not really progressing on a novel hormonal therapy. So I think if you combine all of this population together, there is a very significant number of patients out there who are developing new mCRPC and have not really progressed or exposed to a novel hormonal therapy. And for those patients who have homologous recombination repair mutations, I think enzalutamide plus talazoparib is a solid combination out there.
Yeah, I think you're right. There are many different pathways through which prostate cancer patients can progress. People said there was no population of non-metastatic CRPC, and yet 3 large 1,000+ patient trials managed to accrue, and we find them in our practice. So yes. I agree. It's not everyone's presenting with de novo metastatic hormone sensitive and getting intensified upfront therapy, though of course that's what we hope for those patients does happen in that scenario.